Hello and welcome to ESDO Learning Bytes. My name is Slopovsky and I'm a resident doctor at Digestive Oncology Department at National Cancer Institute in Bratislava, Slovakia. Today's topic will be aimed at cancer-associated thrombosis. In today's topic, we will briefly go over introduction and risk factors, the diagnostic pitfalls of venous thromboembolism, its prevention and treatment, special patient populations, and some take-home messages. Venous thromboembolism, or short VTE, is comprised of deep vein thrombosis (DVT) or pulmonary embolism (PE). Cancer patients have a 9-time higher risk of VTE in comparison to the general population. It's their second cause of mortality, and it decreases their quality of life and increases therapy discontinuation rate. The risk is highest in the first 6 months after the diagnosis, and cancer patients have also an increased risk of bleeding and increased risk of arterial thrombotic events by 3 to 5%. We have several risk factor groups which affect the risk of VTE. First are patient-related, such as comorbidities, single nucleotide polymorphisms, or oncogenic mutations. Then there are the most important risk factors, the disease itself, the cancer itself. Pancreatic cancers, primary brain tumors, lung cancers, and gastric cancers have the highest risk. However, the risk in the population is driven by the most common cancers such as colorectal cancer, lung cancer, or breast cancer. And then there are risk factors which we, as doctors, introduce by surgery, central venous accesses, anti-VEGF treatment, hormonal therapy, and other treatments. The diagnosis of venous thromboembolism can be quite challenging due to its non-specific clinical presentation. For DVT, we can see unilateral or bilateral leg swelling accompanied by pain, redness, or tenderness. The same goes for upper DVTs, especially in patients with central venous accesses. We should be mindful of splanchnic vein thrombosis, especially in GI cancer patients, which can present itself by pain, vomiting, nausea, or bleeding. The typical presentation for pulmonary embolism is shortness of breath, cough, tachycardia, cyanosis, hemoptysis, chest pain, diaphoresis, or syncope. The diagnosis of VTE is made using imaging techniques. For pulmonary embolism, the gold standard is CT pulmonary angiography, and in patients in whom CT cannot be used, we can use lung scintigraphy or echocardiography. The gold standard for deep vein thrombosis or upper vein thrombosis diagnosis is the compression ultrasound, and in patients with splanchnic vein thrombosis, CT scan is the most useful. What about clinical prediction tools and D-dimer levels? Clinical prediction tools such as Wells score or Geneva score and the D-dimer levels are often used in the general population to plan the subsequent steps in the diagnosis of venous thromboembolism. However, these tools shown poor performance in cancer patients. That's why the latest guidelines from European Society for Medical Oncology recommend going straight to imaging techniques in clinical suspicion of VTE without using clinical prediction tools or D-dimer levels. In the primary prevention population, we have several groups of patients. If the patient is admitted with an acute medical illness, for example sepsis, standard dose prophylactic anticoagulation should be used. However, this does not apply to patients admitted only for chemotherapy administration. Patients undergoing surgeries should also receive prophylactic anticoagulation, preferably with low molecular weight heparin, 2 to 12 hours before surgery for up to 10 days, and in patients undergoing high-risk abdominopelvic surgeries, 4 weeks of prophylaxis is recommended. If we cannot use pharmacological prophylaxis, mechanical prophylaxis is an option. Prophylactic anticoagulation with apixaban, rivaroxaban, or low molecular weight heparin is now preferred in outpatients who fall into the high-risk category based upon validated risk assessment tools such as Corona score or Vienna CAT score. Low molecular weight heparin is preferred in patients with GI or GU malignancies where there is higher risk of bleeding with DOACs. And in patients with pancreatic cancers receiving first-line therapy, we can use higher doses of low molecular weight heparin for 3 months. Here we can see one of the most widely used risk assessment tools, the Corona score. Corona score uses site of the primary tumor, some hematological parameters, and BMI for predicting the risk of venous thromboembolism at 2.5 and 6 months. Its advantages are it's simple to use and it's validated. Its disadvantages are low positive predictive value for pancreatic and lung cancers, and it does not take therapy into account, which we know can increase the risk of venous thromboembolism. Moving on to the treatment of VTE. As we can see, DOACs are now endorsed in guidelines for the treatment of BTE in cancer patients. This is because DOACs were shown to be non-inferior to low molecular weight heparin. However, some increases in major bleeding, especially for edoxaban and rivaroxaban, and in patients with upper GI cancers or genitourinary cancers were seen. These differences in bleeding were not seen for apixaban. This is now reflected in guidelines where DOACs should not be used in patients with upper GI cancers and potentially in genitourinary cancers and in patients receiving strong P-glycoprotein or CYP3A inducers or inhibitors. In these patients, low molecular weight heparin are the safest option. So how to choose between various treatment options? In patients with GI or GU malignancies, low molecular weight heparin or apixaban can be used. In patients with renal failure, unfractioned heparin followed by warfarin or low molecular weight heparin can be used if warfarin is not available. In patients with hemodynamic instability or massive DVT or PE, IV unfractioned heparin can be used, and in patients with decreased absorption due to edema or obesity, IV unfractioned heparin is best to use, or warfarin or DOACs. However, for DOACs, we have no data in this patient population. In patients after GI surgeries, low molecular weight heparin is the best option because DOACs are mostly absorbed in the proximal parts of the gastrointestinal system, and therefore in these patients after major resections, probably the absorption of DOACs will be decreased. We should be mindful of drug-to-drug interactions, and if anticoagulation is contraindicated, we can use inferior vena cava filter for prevention of pulmonary embolism. However, it increases the risk of deepening thrombosis. How long should we treat our patients? Long-term treatment, defined as 3 to 6 months, can be considered in patients with incidental pulmonary embolism. In other patients, especially in patients whose cancer is still active, the duration of the treatment is not specified. We should continually reassess the risk and benefit ratio of our treatment, and we should take patient preferences, costs, and prognosis into consideration. So what is the definition of active cancer? Active cancer is cancer diagnosed within the previous 6 months, or recurrent, locally advanced, or metastatic cancer, or cancer for which treatment had been administered within the past 6 months, or hematological cancer that is not in complete remission. The activity of the cancer is important because, as I mentioned on the beginning, cancer itself is the most important risk factor for venous thromboembolism. So, in summary, cancer itself is the most important risk factor for BTE, and different cancers have different BTE risk. If we have a high suspicion for a BTE event, the patient should be evaluated by compression ultrasound or CT pulmonary angiography, regardless of prediction rules or D-dimer levels. Primary prophylaxis is now recommended in patients with high risk for BTE, such as in patients with coroner score of 2 or more. We can use apixaban, rivaroxaban, or low molecular weight heparin. However, DOACs should not be used in patients with upper GI malignancies, possibly genitourinary malignancies, and in patients with drug-to-drug interactions. It's noteworthy that in the primary prophylaxis subgroup, the most benefit is derived for patients with coroner score of 3 or more. For treatment, we have several options. The most commonly used are DOACs or low molecular weight heparin. As I mentioned, in the primary prophylaxis group, DOACs should not be used in patients with GI or genitourinary malignancies and in patients with drug-to-drug interactions. We should always take into account patient characteristics, patient preferences, and expected survival when choosing the optimal anticoagulation regimen. Thank you very much for listening to this ESDO Learning By, and if you have any questions, feel free to contact me on my social media or by email.